already been said, is roughly defined as study of people in their working environment. And typically we think about musculoskeletal disorders with that, but an extended definition would include cognitive and organization pertaining to institution. That's most of what Dr. Unni was talking about some time back. Cognitive really doesn't come into surgery. Decrease the need to memorize and think would help with your headache. What I will primarily be concentrating on here is how to implement the ergonomics that has been talked about already, keeping a posture correct and avoiding a stressful posture for long during surgery. To understand that, primarily we need to understand the adjustments on the microscope. All of us know this has been put in just for completion. It's a single objective, double eyepiece, so that you get a stereopsis. One of the underscored things about the microscope is the stability of the microscope itself depends on the weight of the foot plate, and that doesn't really come into our thought process when we operate. It's because of this weight that the whole thing doesn't topple over. And foot plate has got casters, and or rather wheels. They have locks, and these are the only things that should be fully locked during surgery. Rest of the microscope locks should not be completely locked. You can have a partial frictional resistance so that they don't run around, but it should be easily movable. And most theater personnel find it easy for you to lock the microscope and expect your body to adjust to the height that is fixed. You should know the microscope and insist that they are unlocked. Typically, it has got, is there a pointer? Typically, you have two joints on, I just need the pointer for this one. Typically, you have a pivot on this with a lock and another pivot which will allow for XY gross movements of the swing arms, and a pivot here which will allow for rotation of the microscope. These are for gross initial adjustments. And where most people do not adjust is a swing arm. That is very important because there's a counterweight here, and if you don't adjust that, the whole microscope will move up and down. It takes a little bit of effort to adjust this, and this is what most OT personnel will keep locked. So you should know how to do this. You rotate it in one direction, you are increasing the counterweight. You rotate it in the other direction, you're decreasing it. So you should be at a position where the microscope stays where you place it. It doesn't go up freely, go down freely from wherever you place. If it happens while you're operating, the focus slowly goes off. You keep readjusting, it adds to your strain and tension. You will end up with the crouch position, and you'll be blaming the microscope, but this is probably all that is wrong. And this is another thing that is stressed, your head position while you operate. And how does it come into ophthalmic surgery? You can have microscopes where you're looking straight ahead and your objective is facing down. That's what you're aiming for. You get the lower end microscopes with fixed heads, which can be 45 degree as so, or you can opt for a 90 degree. Preferable to opt for a 90 degree if you have a fixed eyepiece on your microscope. Otherwise, your aim is to look straight ahead while you're operating, so the eyepiece should be adjusted so that it's straight ahead and you're not having to bend your head. XY should be centered at the start so that you have less of moving around with your feet and gross movements in the middle of the surgery, so it should be centered. That's just for completion. IPD is important. You have to keep both eyes open and see with both eyes at the same time. If you are converging or diverging or trying to fuse during surgery, that again adds to astenopia. That also comes into ergonomics. So how to do that is to keep both eyes open, widen the IPD till there are two circles, and slowly bring them in till there's only one circle completely eliminated. You look away and check again, because it's easy to use accommodative convergence with something nearby, so make sure you're not accommodating while you're doing this. I've seen people trying to adjust one eye at a time. You're doing a cover test. It is not physiological. If you have a phoria, you're going to adjust your IPD with that phoria in place. So this is what I'm trying to tell you. Start with seeing two images. When they're too wide, you see the inner sides of the IPS tubes. So there'll be a dark area in the middle. This is the endpoint you want. If you go beyond, you would see darker crescents on the outside because you're seeing the outer tubes, outer sides of the IPS tubes. Microscope is just one of the components that we need to keep our posture right. To be comfortable in microsurgery, you need to pay attention to your back. It should be relaxed and straight, not bent and overstretched, and you should be easily able to reach the foot pedals, and neck should be comfortably positioned, preferably looking straight ahead. So you need a tilt to the microscope always. So if you're looking at this would be a relatively better position. You would have a much better red glow if you have the microscope banged straight down, but then you will have to tilt that much forward to get to that, and that is a constant stress on your low back, and at the end of the surgery, you'll find out you got a backache. And when you're shifting to a temporal surgery, if you're doing a clear corneal phaco, you're sitting temporally, you need the microscope to tilt even more so that your back is straight. So the tilt of the microscope decides on how straight your back is. At the start itself, make sure you're right. Foot pedals are configured, and you figure out this configuration to start with so that you don't get confused in the middle. Your knee should not be hitting the table while using the foot pedal, and all your joints should not be at the end of the range of their movement. So your ankle should not be fully hyperextended or fully flexed when you're just hitting the pedal, because you still need to move after that. The chair should not be too low, chair should not be too high. End of surgery, you need to get up, and why I said chair should not be too low is to reduce the strain on your knee while you get up. Your hands have to stay sterile at the start, and they're soiled at the end, so you cannot put a hand down and help your getting up. You cannot get your hands to assist, like if you're getting up from this chair, you can use your armrest to help your knee. You cannot do that. And over time, by the time you reach my age, you will start feeling it. I do feel it. So that's what we're trying to do. All joints, none of them are in a hyperextended or end of your range of mobility, including the ankle. To achieve this, what I would say is to adjust the chair up and down first, then you have your table up and down possibility and the microscope up and down possibility. All these combined together can accommodate most surgeon profiles as far as height is concerned. Once the surgery starts, we concentrate on what is immediately there for the patient, and we forget that we are in a stress position, and you'll feel the pain only at the end. And that would limit the amount of surgeries you can possibly do. So the chair height is first, locate the foot pedals are in range, and the microscope height next, and then raise the table is what I do. This is what I do. First, I make sure that I can get to the pedals easily and the chair height is appropriate. This is a set pattern I have before every surgery actually. Now I bring the microscope to what is my comfortable level. I'm not in focus at this point in time. I have learned to adjust my IPD with that defocus image because I cannot accommodate. That also helps a little bit. So once that is done, the foot pedal of the table is right there, and that is what I use to focus the image now and then proceed to surgery. So the table comes up last. So once you do that, you're not in a stress position to start the surgery, and you can keep operating for a longer time. You can keep operating for a bigger number of surgeries. So it's a future that we're looking at when you're training. So get used to ergonomic postures during surgery. It's easy to do one case crouched and stretched and things like that. But over time, we are planning on being able to do longer, more complex cases. That is why all those veteran surgeons were the ones that are listed in the articles Madam quoted. That's because their surgeries tend to be longer. A cataract surgeon, I'm typically, primarily most of the cases I do is cataract. It's over in less than 15 minutes. but a VR surgery can take 3-4 hours sometimes. So you're looking at more complex cases, more numbers, depending on the subspecialty you're going into. And as we age, all these will contribute to your back problems, your shoulder problems, and these may stop your surgeries altogether. So it's important to be aware of this at the start of your training itself. Almost all movements in ophthalmic surgery are at the finger, pill rolling, finger grip, and only the fine muscles need to move. For that to be controlled, the wrist and above have to be very steady and not using any power to hold on. You start a tremor in your shoulder, it transmits all the way into your surgical field. So find and use wrist supports wherever possible. It could be the patient's forehead, the patient's zygoma, head of the table, whatever is handy. You anchor one little finger or wrist down so that your hand is steady. Also, the axial muscles have to be relaxed. You cannot allow them to tire and tremor, so your starting posture decides how well your surgery will go through. Thank you.